Welcome to the Department of Clinical Oncology. Today we are covering a critical safety protocol, the prevention and management of chemotherapy extravasation. Extravasation occurs when a chemotherapeutic agent leaks from a vessel into the surrounding tissue, which can lead to severe injury, blistering, or even necrosis. This guideline provides the framework for every nurse in our unit to ensure prompt and proper management to minimize patient harm. All new staff are required to complete the preceptorship program to be fully qualified under this protocol. Not all chemo drugs react the same way if they leak. We classify them into three main categories. Vesicants. These are the most dangerous and can cause lasting necrosis. They are split into DNA binding, like anthracyclines, and non-DNA binding, like vinca alkaloids. Irritants. These cause inflammation, aching, or phlebitis at the site, but usually don't cause permanent tissue damage. Common examples include cisplatin and carboplatin. Others, drugs like fluorouracil, generally cause little to no reaction if they leak. Always check the classification list in the protocol if you are unsure about the agent you are administering. Prevention is our first line of defense. When cannulating, use a 22 to 24 gauge catheter. For any vesicant, you must use a newly established cannula. Winged infusion sets are strictly prohibited for chemo infusions or vesicant boluses. Always start your site selection from distal to proximal veins. Avoid joints, the inner wrist, or the antecubital fossa, as these areas increase the risk of complications and are harder to monitor. Constant vigilance is required during administration. You must verify the patency of the site before starting. For vesicant infusions, check the site every 5 to 10 minutes. Ensure the dressing is transparent so you can clearly see the insertion site. Educate your patient to tell you immediately if they feel any burning, stinging, or pain. Remember, vesicants should not be put on an infusion pump unless the patient has a central venous access device, CVAD. If you suspect extravasation, you must act fast. Stop the infusion immediately and disconnect the drip, but do not remove the cannula yet. Reassure the patient and use a 10 milliliter syringe to aspirate as much of the drug as possible through the existing cannula. Notify the doctor immediately. Identify the drug to determine the correct antidote and whether we need a cold or warm pack. Assist the doctor in administering any prescribed antidotes before the cannula is finally removed. All antidotes must be prescribed by a doctor on the MAR or IPMOE. For anthracyclines, we use topical 99% DMSO. You'll apply a thin layer to an area twice the size of the injury and let it air dry. For vinca alkaloids, the doctor will use hyaluronidase injected subcutaneously, ideally within 1 hour of the event. For mechlorethamine, sodium thiosulfate is used to prevent tissue destruction. Note that nurses assist, but the actual IV or subcutaneous injection of an antidote is performed by the doctor. Thermal therapy is equally specific. For vinca alkaloids and epipolyphyllotoxins, apply a warm compress for 20 minutes, 4 times daily, for 48 hours to help disperse the drug. For most other agents, use a cold compress to cause vasoconstriction and limit the spread. After the immediate event, elevate the affected limb and provide the patient with written home care instructions. Ensure they know to avoid tight movements, like lifting heavy objects or wringing towels. Finally, documentation is vital. Record the event in the medical record and fill out the extravasation record. Use the assessment tool to grade skin color, integrity, and pain. Mark the affected area with a soft-tipped pen and take clinical photos if indicated. Arrange a follow-up assessment and advise the patient to seek immediate help if symptoms like blistering or increased pain occur.